So my name is Dylan Jacobus. I am a general surgeon in rural Maine. I completed my residency just last June, so I'm in my first year as an attending, and it's been interesting. A lot more difficult than I ever thought it was going to be. I have no disclosures. So, the basis of at least what I thought I was supposed to bring to the talk today was a little bit defining what is a rural surgeon, where are we practicing, who are these people that we hear about when we hear in the committees people talking about rural surgery, and what do our lives look like, and why is it such an issue for us being out there and trying to take care of our patients with less than what some of the community hospitals or what some of the tertiary referral centers have. So this is where I work. It's called Maine Coast Hospital. About 10 years ago, it's called Maine Coast Memorial Hospital, but then it got bought out by the Northern Light Health System. It's a group of 10 hospitals throughout Maine, but specifically my facility, 64-bed hospital. We have 8 ICU beds with no intensivists. The hospitalists are the people that manage the ICU. We have 4 operating rooms with 1 full-time anesthesiologist, and the remainder of them are contracted nurse anesthetists. We have 2 endo suites, which we don't use because we don't have enough staff to run them. And this is marketed towards the community as a full-service hospital. That's what it says on our website. So the expectations of what we're able to provide, I think, are being set up by people that may not know what exactly we're doing. So in addition to the hospital, we also have swing beds, which I'm sure a lot of you are familiar with, but it's not uncommon for us to have all 8 of our swing beds full and to have people there for multiple months at a time, because we have 1 rehab facility in the county that is full and has been full since the beginning of COVID. So it's very difficult to get disposition for our patients. And we are not a modernized facility. Almost all of our rooms are shared rooms. So it's kind of like the old VAs where everyone has a roommate and they get to check in on each other. This is where I work. The orange dot is me. I'm right on the coast of Maine. It is about 20 minutes from Bar Harbor, and I'm about an hour from Bangor. And you can see my catchment area is all along the coast of Maine and into down east Maine, which wasn't a term that I was familiar with. To me, it seems north on the map, but technically it's more east. I'm still getting to understand the geography of the state, but this doesn't show a good representation of how far apart these places are and how far people have to travel. For me to get from my house to an airport, the airport is 30 miles away, but it takes me an hour and a half to get there because it's all 2-lane back roads. And usually dense fog in the morning. So it's very difficult to travel, and these patients are coming from a long way away, and they don't like the city. They don't like to go to Bangor. They don't like to go to Portland. They don't like to go to Augusta. Like you had mentioned earlier, these people would rather go somewhere they're familiar with than have to brave going into the city. And that puts a lot of onus on the healthcare system to make sure that these patients are getting the appropriate treatment, which can prove to be quite challenging. And so these are, when I was thinking about what actually makes it difficult for me to be where I am, who I am, and trying to take care of the people that I'm taking care of, kind of broke it down into 2 aspects. Part of it there are some difficult factors that the patients bring with them. Most of them, these are kind of immodifiable risk factors that the patients have themselves. Where they live in the state, if they're on a peninsula, if they live on an island, is there a ferry to get them to the mainland? What are the tides doing? So it's very difficult for the patients to get transportation to medical facilities. There's also the patient's schedule, working around their job. Most of my patients either don't have a job or they have multiple jobs just to provide for their families, which also goes into the aspect of money. The healthcare in my state is very difficult for people to get disability or get Medicaid or get state-funded healthcare, and that plays a big role in patients presenting to me with diseases often late in their course. System mistrust, even though they are rural, they still have access to the internet, and so they're able to Google our healthcare system and see our terrible reviews and just choose not to come because they see we have a 1-star review because apparently we don't know what we're doing and we don't know how to take care of patients. So that plays a big role in whether or not people want to come to our hospital. And word of mouth, if they had a cousin that had a bad experience, that spreads a lot further in a smaller community and carries with it a lot more weight than it would in Kansas City or Los Angeles or somewhere else. You're not as insulated from the community. Then there is my facility, me, everything that I bring to the table, and the healthcare system that I work in. 64-bed full-service hospital that has no in-house radiology full-time. I have no in-house subspecialty call. It's just me. Even though the hospitalists are the doctors providing the intensive care, they don't do any invasive procedures. They don't do A-lines. They don't do central lines. They don't do any bedside abscess drainages or debridements. They merely manage the medications, and they're usually not comfortable with intubations, and our nurse anesthetists are not on site, so that may also rely on me. And I am expected to do a lot and provide patients with a high quality of care, and I'm looked at very strenuously if my patients aren't doing well or if they aren't getting the same type of care they would be getting at a tertiary referral center. They expect to get the same care where they go as if they are going to any other hospital in the country. They don't necessarily make that distinction. They say, I'm going to the hospital to get care. It should be the same here as it is anywhere else. And we already mentioned, like I said, our tertiary facilities are full. We have a 15-bed ED, and we usually have about 10 holds because we can't find beds for people around the state, and our hospital's full. I thought I would bring a couple cases forward so you could kind of understand what I see on a daily basis and why it is difficult to do what we do where we do it. So this was a patient that I saw in clinic, a 64-year-old lady who came to me with just complaints of rectal pain. She said, it hurts when I have a bowel movement, it's sharp pain, sometimes I pass some blood, I'm not sure what's going on, can you take a look, doc, and help me out? But she wouldn't let me examine her in clinic because she was too tender. So we went to the operating room. I was able to do a colonoscopy, even though her last one was in 2016 and it was clean. Based on her symptoms, I felt she probably needed another one. She had a large 5-centimeter mass right at the anal verge, and pathology came back moderately differentiated adenocarcinoma. At the University of Wisconsin, where I trained, I would know exactly what to do. They'd get referred to the multidisciplinary clinic, they'd have a meeting with the colorectal surgeon, all of it would be very streamlined, and the patient would kind of fit into a pathway, and I wouldn't have to worry about it. That's not what I'm able to do. I don't have an MRI at my facility or within an hour and a half of me that can do a protocolized MRI for rectal cancer. If the patient is going to need any radiation, same thing. They don't have access to that in the community. Oncology, although we have an infusion center in town and at the hospital, the oncologist is only in our hospital 1 day a month, and so they would have to be getting their appointments over an hour away. And when I say over an hour away, that's an hour away from the hospital, not from where the patients live. So that could be anywhere 6-7 hours from where they live, depending on the tides, to get to the hospital or to get to the clinic appointment. And then what if I wasn't part of Northern Light Health System and I was just a standalone hospital that hadn't been bought out yet? Where would I refer these people, and how would I know that they're getting treatment and they didn't just decide to go home and not do anything about it, which is a fair option to some people. So this just gets very complicated, where normally I would, in a big hospital, I'd just be able to send them to the colorectal surgeon and be taken care of. Now I am essentially their primary care provider and holding their hand and trying to make sure that they're getting the care that they need. This second case is actually a patient that I saw 2 weeks after starting. 71-year-old gentleman who vacations in Maine, but because of COVID, he decided to move there permanently. He has significant comorbidities, elevated BMI, he has poorly controlled diabetes, recurrent episodes of urosepsis related to his colovesicular and complicated diverticular disease, and he's also on 20 milligrams of prednisone daily for his PMR. His recent colonoscopy was negative for any large masses or tumors, and a CT scan shows an obvious colovesicular fistula. And he said, "Doc, not going anywhere." You got to do it. I'm not going anywhere else. And this is me 2 weeks in, and my partner said, oh, okay, yeah, sounds like something you can do, sure. And I mean, what do you do? So how do I even know that this patient is fit to undergo an operation? He doesn't have a primary care provider because he vacations in Maine, but doesn't really, he lives here now. How do I get him preoperative clearance? If I'm really providing up-to-date medical care, is he a candidate for ERAS? How do I know? Is this, I don't know, I'm the only person doing it here in the community. Is my anesthesia team going to be comfortable doing a case like this? I only have one full-time anesthesiologist. And then how do I even do the operation? Again, at UW, I know how to do this. I call urology. They put access catheters in. I have my senior partner. I have the senior resident. I have the fellow. We can always open if we need to. Do I even have the supplies? Do I have a stapler? Do I have a TA stapler at the hospital? Do I have a laparoscopic stapler? These are all things that I didn't even think I was going to have to worry about. And then when I get into the hospital, half of this stuff we don't even have, so it has to be arranged ahead of time or transferred from another facility to get. And then, what do I do during the operation? Do I divert him? Do the nurses on the floor know how to take care of the patient? I can tell you my patient didn't get out of bed for 4 days because we needed to wait for physical therapy to get the patient out of bed because the nurses said they were worried about their licensure if the patient fell. So now, do I feel comfortable doing procedures at this hospital anymore? So it's just very difficult, and these are very complicated situations when the patients expect us to provide high quality, up-to-date care. And then this is a common general surgery case, acute care case, no problem. A 41-year-old lady comes in, looks like maybe she has some common bile duct stones. Oh, but wait, it's 5:30 p.m. on Thursday. No ultrasound. They get a CT scan. Doesn't really look abnormal, but based on her lab studies, I'm concerned she has cholelocoko. Now I can't get an MRCP until the next week. What do? Do I just sit on this patient? Do I operate on them without a known diagnosis? I think many, many years ago, there would be the ability to do that, but now, with the way that things are, the opportunity for surgical risk is much lower. We're not allowed to have 10% negative, diagnostic laparoscopies for appendicitis. Now that we have imaging, we're expected to know what we're operating on a patient for. And so what do we do with the patient? I can't send them to another hospital to get their studies because they're all full. There's no ERCP in my facility. Sometimes we have a day trip where they can go to Portland or they can go to Bangor, get their procedure and come back, and we do the remainder of their care at our hospital. Well, it turns out all the other GI docs in the state are out at their conference. No joke, like there's no one in the state that's doing ERCPs. And then what do? Let's say I do a lap chole with an IOC. What if it's a big stone and I can't get it out? Do I do a bile duct exploration? Can I get the spyglass and do a bile duct endoscopy? It's just all these things become so much more complicated when you're in a situation with limited resources. And it's just, like I said, it's much more difficult than I anticipated it was going to be. And so why is it hard? I think professional isolation is part of it. This conference started at the beginning of the week, and I wasn't able to be here because I couldn't take that time off for my patients. So I had to miss the first 3 days of the conference because I was taking care of my patients. Lack of resources at the hospital. Money plays a huge role into what our hospital is able to afford. We operate on a very tight budget. And then with recruitment and retention of surgeons to rural areas, it's a very difficult work-life balance. Thankfully, I have a partner and we're able to work a week on and a week off. But sometimes if you're at a critical access hospital, you're the only person there and you're on call 24/7 until some locums comes in to give you some relief. And then professionally, I always feel conflicted. I want to do the right thing for my patient, and I know that maybe if they went somewhere else, they would be getting a different level of care or maybe different treatment. But I have to respect their autonomy, and I have to know that they're okay accepting these risks so long as they can stay close to their family and be where they feel comfortable at home. So that's just a brief overview of a couple days in my life, and it's very difficult. That's all I have to say. Yeah. Thanks.